Good afternoon, and welcome to another edition of the Stanford Health Policy Forum. My name is Keith Humphreys. I chair the advisory group of the forum, which is an educational program sponsored by the Office of our Dean, Dr. Lloyd Minor, and very ably staffed by Aaron Hiscox and Robin Daines. The forum convenes 2 or 3 times a year to bring top health decision makers and thinkers to campus to engage with us about cutting-edge health policy issues. If you want to know more about the forum, for example, watch videos of prior events or find out about future events, you can do that on our recently retooled and very spiffy-looking website, which is at Health Policy Forum. That's all one word, healthpolicyforum.stanford.edu. Our topic today is the high cost of healthcare, which most people consider the defining quality of the U.S. healthcare system. It's hard to express how much money we spend on healthcare. This year it'll be coming close to $3 trillion. If you, an analogy I found helpful, which was offered by a prior guest at the forum, Dr. Zika Manuel, is that we spend as much on healthcare as people in France spend on everything. In other words, their economy is literally about the same size as our healthcare system. And yet, despite that, we don't have strong evidence of great value for all of that spending. And so our topic today is why is that so and what might be done to make it better. And to lead us in that discussion, we have 2 physician scholars who are extremely well qualified to address these issues. So let me introduce them to you. Starting on your right is Dr. Doug Owens. Doug is the Henry J. Kaiser Professor of Medicine and the Director of the Center for Health Policy and Primary Care and Outcomes Research. In addition to being a practicing internist, he's also an internationally recognized scholar in the areas of cost effectiveness, cost of care, quality of care. Then in the middle is Dr. Elizabeth Rosenthal. Elizabeth, we are proud to say, is a Stanford alum, undergrad here in biology with Doug, which is sort of a nice connection. Then got a Marshall Scholarship, went to Cambridge, and then came back to Harvard to get her MD. She practiced medicine for a while and then moved on to being a senior writer at New York Times, and that's, I'm sure, a series many of you know, Paying Till It Hurts, which is absolutely exceptional in combining the policy realities with the human experience of, for example, getting a $117,000 bill from a doctor you'd never heard of in your mailbox, or shopping around for a hip replacement in, in Bermuda. So that series is really the thing that caught our attention because it's so good at bringing very complicated issues out in an understandable way, and that's one of her many gifts. So I'm delighted she would come to Stanford. And then our discussion today will be led by Paul Costello, as usual. He is the head of media and communication at the medical school after a long and distinguished career as spokesperson for many important figures, including First Lady Rosalind Carter. We'll go up to about the hour on the stage, and then we'll open it up for your questions and comments. So enjoy, and thank you for coming.
Thank you, everyone, for joining us today. It's impossible, I think, to start a conversation about healthcare today without raising the issue of Ebola. So I want to start there, and how does it weigh into this? And, one would think that it would not weigh into costs, but Libby, as you've written about, everything weighs into costs. So I wondered if each of you would address what you've been thinking about in the past few months of you seeing the Ebola crisis move from West Africa here into the U.S., and what you think, how it's going to rebound, and how it's going to impact the overall nature of costs.
Well, I'll start. I mean, whenever I watch any healthcare crisis after my last 2 years of doing this series, I think immediately about, wow, what's that bill going to look like? But I think Ebola is one of those things that the U.S. healthcare system can do really well. We're really good at that kind of isolation, high-tech care. That first experience at Texas Presbyterian notwithstanding, I did wonder, and this is complete speculation, about what happens when an uninsured person comes into an emergency room with a serious illness, and what are the incentives going on in the back of the physician's mind and the hospital administrator's mind in terms of, do we really need to admit this guy now, or maybe we can send him out and he won't have to come in. I mean, clearly they did a lot of tests. They didn't just say, oh, forget about it, he'll be fine. But, I think money is in the back of everyone's mind in this system, and certainly I've spoken to enough hospital administrators and physicians and to know that it's just there in the background. Who's going to pay for this? Are we going to be reimbursed? What are the pressures from the finance guys at that hospital to say, try not to admit a patient who's uninsured?
Send them to Emory, send them to Nebraska.
Well, or just send them out and hope that they'll be okay on the outside, whereas if you get a person with good insurance, and I'll just give you, I mean, my daughter clearly didn't have Ebola, but during finals at Princeton, she went into a local hospital with a stomach ache and got a $32,000 workup that was completely unnecessary, I think. And I think it's the kind of workup that you get. I mean, I guess what I'm saying is so much of what we get depends on our insurance and the financial considerations in the background. I think if she was uninsured, she wouldn't have gotten the, and I will say this because I think it's shameful, the $12,000 CAT scan or the $9,000 sonogram. She was a kid during finals who had a stomachache.
Doug, what have you been thinking about in the past few months?
Well, I'd just say first, $32,000, she must have gotten a discount.
She did. Our insurance paid, I think $1,200 for the whole ordeal, but I was, because I'm a wonk and I get apoplectic about these things, I couldn't resist calling and saying, what on earth are you thinking? Why did you do this? I didn't get any satisfying answers, though.
Would you like to see it on the front page of the New York Times?
No, no personal stories. So.
Paul, I think there's several things. First, people say all politics is local. I think we should be clear that infectious disease is global. So what happened in West Africa affects us now, clearly. In Santa Clara County, when malaria goes up in India, malaria cases go up in Santa Clara County. When typhoid goes up in India, typhoid goes up in Santa Clara County. We had 2 of the 8 cases of SARS in the United States here in Santa Clara County. And we have one of the highest rates of liver cancer in the United States in Santa Clara County because of hepatitis B. About 30 to 40% of the people who live here are foreign-born. So it's global, really. And so that means we have to care about and pay attention to what's happening all over the world. So that's one thing, is that we need to think very broadly and be interested broadly. Secondly, I think what's happened here has exposed sort of our public health system and sometimes lack of coordination. There are a number of people speaking to this on federal level, state level, local level, et cetera. As terrible as Ebola is in Africa, it's really here. Of course, there have been a handful of cases. But if something like pandemic flu came along, then you'd have something on a completely, wholly different order of magnitude. And we should take this as a wake-up call in terms of how we're thinking about our public health and how that's organized and how we fund it to be prepared. So Nair Kazemi, who's here at Stanford, did some modeling on flu. And in New York City, a pandemic flu with modest mortality would cause 200 to 700 deaths per day. Something like that would be really very different. And then finally, I think the risk, how you communicate risk in a problem in a time like this is very important. And I think you both would know more about this than I do, and you've seen a lot of statements that I think probably were ill-considered in terms of how people have communicated about this. All of these things, and it's imposing great costs on us now. Public health people are working round the clock. Stanford has certainly been spending a great deal of time and energy resources preparing, as have most hospitals in the U.S. So what's happened in West Africa really has imposed very substantial costs on us.
Libby, you started your series a year ago plus, and if you were to look at 30,000 feet of the problems of the healthcare system as far as costs, what would you identify as some of the core issues that are there and that we're still grappling with a year after Obamacare? And has Obamacare, the Affordable Care Act, made any impact there?
Well, I think, I mean, first of all, I think the issues and the problems are so diffuse, which is one of the messages and why the series has gone on for so long. I think there's a tendency to be very reductionist when we talk about healthcare reform in our system, and to say, oh, it's the hospitals, it's the insurers, it's pharma, and it's we're all so codependent, and it's all so intertwined that, I think I could start listing off, but I think the ultimate problem is that our system has shifted over the time since my dad was a physician, in the 60s and 70s, to a focus where patient health was the center, to a situation today where patient health is still nominally the center, but finances dictate what we do, and the financial incentives are so powerful. And I think, one of my messages to patients is, we're responsible too, in the sense of, when I have friends who go into a hospital in New York City, they'll say, oh, it's a great hospital, there's free coffee in the lobby, right? Or it's all private rooms. And so I think, we're all part of this together. And yes, the hospitals maybe have overbuilt and the charge masters are a problem, but they're playing to patient expectations and demands. So I think every part of our system is going to have to recalibrate. And that doesn't mean, I know there are people who say, okay, single payer, and I think that would be one way to do it. I don't think that's what's going to happen in this country, but I think if every part of our system does its piece of recalibration to move away, to think a little bit less about the financial incentives, that's really, really important. And I think some of that will come from, do I think anything will come from government? Not at a national level right at this moment, but some of the states have become more active. Attorney generals can become more active. Some physician groups have become more active. Hospitals are changing the way they think about it. I mean, one of the most heartening things to me, and why I like speaking at a place like this, is there's been a tremendous response, not just from patients who are frustrated, but also from physicians. The head of a cardiac transplant department had called me, someone from Yale, and said, I want to be part of this because I don't think our costs are in line with my mission of curing people. So I think, there's distress at every level, which to me means there's hope for change too.
Doug, what do you see as some of the sunlight on the horizon? Some of the, Libby's been talking about the physicians and the patient responsibility and the change of culture that needs to take place in all sectors. What do you see as some of the bright spots out there?
Well, I think, Paul, if you think about the main challenges the healthcare system faces, it would be cost, quality, and access. And I think the ACA is primarily going to affect access. So I think that's a bright spot. 7 million people signed up. There will be more next year. So I think that is progress. At the same time, even with that, we're of developed countries, we're probably dead last in terms of access to care. And even when people have insurance, that doesn't mean that the deductibles and copays aren't so high that they can access care. And another issue is going to be, as Medicaid expands and more people sign up, will there really be physicians to take care of these people? So those are remaining sort of fundamental challenges, but I think that the ACA's primary contribution is going to be likely in the area of access, not in the area of cost control or quality.
Libby, one of the significant pieces you had in last month that had an enormous amount of feedback and comments was the front page piece about a surprise bill of $117,000 that a patient received. And you describe it as an increasingly common occurrence. Yeah. What's happening here? Where do you see that? How do you see that? And how that patient found out about it was sort of by the detail looking at his bill. And what does it mean to the system? What's happening here?
Well, I think, what we see in the system and what so many of these stories reflect is physicians feel like their income is being squeezed. Hospitals are better positioned, particularly big consolidated health systems, to push back against insurers. So the insurers are trying to push back on payments, and hospitals and physicians are looking, and sometimes to unsustainable levels, so they're looking to recoup some of that lost income in other ways. And I think what's lost in that very real tug of war is the fact that the patients are kind of held hostage in the middle, and that's what's distressing to me. So, what was happening in that particular case? I did a follow-up about smaller examples of surprise charges, which I think are more typical. But, in New York, the primary surgeon and I have to say everyone in the series liked their medical care. No one said, I hated my doctor. They all liked their medical care. They were all treated in ways that they thought were good. They got better. So these are not generally disgruntled patients. What upset them was the payment and the bills. So, this patient tried to be a good consumer, and this is another theme that, we keep saying to people, oh, you have to be a good consumer of healthcare. But our system, if we want to go that route, is not set up to allow people to do that. So Peter Dreyer, who was the main character in the case, he'd found a neurosurgeon he liked. He'd ended up with a negotiated rate getting pre-approval, and that neurosurgeon, I believe, took something around $6,000 for his cervical spine surgery. And again, this wasn't so much controversial surgery. He researched it. He realized he didn't need it. He didn't run into it quickly. But somehow he ended up with all these things on a bill that he couldn't have been a good consumer about. I mean, there was the $117,000 bill from the assistant neurosurgeon. Now, my guess is, and I've since discovered that sometimes this is a kind of what I would call very suspect practice within a group, where a few people will be in network and others will be out of network. And the in-network guys will get the cases, and then the out-of-network guys will turn up and help out with the surgery, and they share revenues. I think there are some reasonable legal challenges to that. But, the thing that in some ways disturbed me more, which I heard from a lot of patients afterwards, was as he was being rolled into the operating room, he was asked to sign a form saying, I understand that my neurologic monitoring during surgery is not covered by my insurance, so I'll pay. Now, that, and I have since heard that from lots of patients undergoing neurosurgery. So what does that mean for the way we're doing healthcare? What are you supposed to say? Oh, yeah, I'm going to be a good consumer. I'll go without the monitoring. I mean, that's really not, for anyone who cares about health and about morals and doing the right thing, that to me is just out of line. And since, I did a follow-up story that appeared over the weekend about kind of funny new charges. One was a therapist who was, and very few therapists are in insurance networks because the rates are very low, right? So that therapist had figured out, well, I can charge both $100, my negotiated rate for the therapy, and then $100 for a room rental fee. Okay, that's not something I've seen on medical bills. I saw another thing, and I see all these bills, an ER that was clearly trying to augment its cash flow. They had something called, and I've seen trauma team activation fees, which you can argue about, is that justified or not, but at least people, I've worked in an ER, sometimes there's an ambulance coming in, the trauma team is invaluable and it's a lot of people. But this one was for a non-critical patient trauma team activation. So what does that mean? A trauma team for someone who doesn't really need a trauma team? That was for $2,500. Sling charges, and I know, okay, so someone will say, well, that's durable medical equipment and we charge for that. I can tell you, I've had lots of kids with broken arms, and the sling was never charged before. Now it's $150 for a sling. So I think, providers sometimes for good reasons because their reimbursements from insurers are overly low, try and make that up in other ways. But I think the thing that we all have to realize is if the battle is between the providers and the insurers, it's the patient's health that's kind of suffering for that, and that's not okay.
Why is the geography so particularly odd in this, that can happen in New York City, in the Midwest, it can be totally different, in the West Coast, South? Why is the geography so specifically strange when it comes to healthcare costs?
Well, it is and it isn't. I think, we find what I've found is the games are slightly different in every zip code, but there are games in every zip code nonetheless. And I think it's partly that doctors in one area or providers in one area, the Suffolk County seems to be a kind of little epicenter of high neurosurgical assistant fees. And I think partly what happens is, is that the doctors who are just trying to do their jobs and working really hard and see their reimbursement cut, look at the guy practicing or the woman practicing down the street and think, what kind of a schmuck am I? I'm just working, doing, trying to keep my practice going and not getting paid for it, and everyone else is doing it. So there is this element of groupthink, and it gets kind of perpetuated, and this is something that I think, is an interesting system issue, by some of these database crunchers who try and figure out what's reasonable and customary in different zip codes. So if you look at, on fairhealth.com at reasonable and customary for cholecystectomy in Nassau County, it will be something like $36,000 to $40,000 because surgeons there charge a lot. If you look over the border in Queens, it will be $6,000 to $8,000. So I think usual and customary is no longer probably a good way to do things, and the variation is tremendous, which tells you, to me, that we're paying too much. But the games differ in different parts of the country.
You used the word games twice.
Yeah. Sorry.
And I know it's interesting, so I want to go in a little in that.
Yeah, I should
Doug,
have said
reflect on the word games, and it sounds like what you're saying, Libby, if I'm right or wrong, is that physicians in these networks are trying to stay one step ahead of the regulations, one step ahead of. Is that what's happening here?
Well, I guess I would say that they're responding to the economic incentives that they face. And there are people in the audience who could say much more about this than I can. But they couldn't do this if we didn't have a system that had economic incentives that allowed it. And you couldn't charge $117,000 for a 2-hour procedure, which, by the way, is probably 2/3 the annual income of some primary care providers. So I think that's one of the fundamental things that we would have to fix if we're going to have real reform, is to have economic incentives that reward the kinds of things that we want the healthcare system to do: take care of people, keep them healthy. And then people will use that same ingenuity that they are using to figure out how to keep their practice afloat, potentially for things that we think are more critical aims for the healthcare system. So I think the economic incentives are really, really crucial.
And I don't mean games. I probably should have used the word strategy more. And I don't think it's partly the strategic moves that businesses do all the time, that the insurers are doing, that pharma is doing. Oh, look, here's a generic drug that's probably underpriced relative to what people will pay for it. So they raise the price and see, and it works, So I think everyone is being strategic, except the poor patients who, if you're just dealing with your care, you have no leverage really to be strategic, and you don't have the information to do it, and you don't have the knowledge. So I think the patients in this game of strategy, which you would expect when it's a system, where everyone is feeling somewhat crunched now and trying to make what they do financially viable. The poor patients are the ones that don't have that option, and I can't tell you how many patient homes I've been in the past year and a half, where you see people with these crazy payment plans of, for things that they probably needed, but they certainly didn't need to have them cost as much as they did.
What are some of those examples?
Oh, I was interviewing, he was a retired CIA, I believe. He and his wife have a saddle shop in New Hampshire, and he had two things. He'd had a cataract surgery that was billed at about $12,000, I think, for the physician fee, and he had a colonoscopy, my favorite procedure, which was billed at about $5,000 plus. He ended up sending me, it was a normal colonoscopy, and his GI doctor sent him 18 months later a reminder saying, oh, it's time to think about another colonoscopy. Well, what's that about? And he said to me, he called me, he said, do I really, I'm like, Dr. Rosenthal, who hasn't practiced in 20 years, do you think I really need this? And I said, I don't know. These reminder letters are just creepy. So, I think that, but he and his wife had these binders full of bills, and they're pretty successful business people, but they're small business owners. They have big co-pays, and they have a very high deductible plan, and so they're paying off this, $200 a month for the more creative patients faced with this dilemma, who I've run into recently, I think my patients are getting increasingly defiant over the course of the 2 years. I had one newspaper person from Ohio who'd been in a bike crash, and she was objecting to an ambulance bill that was something like $2,000 to take her in. And it wasn't even like she said her husband could have driven her in, but someone called an ambulance, and it was there, and it was the local fire department, so she didn't really think much of it. And so she tried to negotiate it down to $400, and they said, no, it's $2,000 or nothing. Or you can set up a payment plan. So she set up a payment plan where she's paying $5 a month, for her life and the lives of her children or something like that. So, but I think it's a sign of dysfunction, not a sign of success.
And when you go in the homes of patients, consumers, and talk to them, is there a thread that runs through this? Are people really, are they just exasperated with the system? Are they fearful of it? Do they not understand? What's the thread that binds these patients together besides the overwhelming amount of dollars they may owe?
I think they're frustrated, they're scared, I think we've probably all felt it. I mean, I'm trained as a doctor, and I know every time I open a bill, I'm like, wow, what's that about? Or I don't understand what that charge is. I have to call the hospital and say, what is that? You have to negotiate. You think, why is it that much? There's very little transparency. And I think what I'm hearing from patients, and why the series has been as successful as it has been, is that, we've had more comments than, on the first day of the series, we had more comments than Nate Silver on Election Day. So, that the earmark of success. Yeah. But, I've gotten tens of thousands of stories, and I think the common thread is that people are frustrated. They don't know what to do, and these are New York Times readers, so they're by and large people with insurance, well-educated, who have access to healthcare. We're not even talking about people who are not that lucky. And there's no place to put that frustration. And I think that's mostly why, again, it's kind of sad that their outlet is to comment in the New York Times, but no politician is making a big deal of this. They are, and they are reluctant to say to their doctors, look, I just can't afford this. They're afraid to ask up front about price. They think it's kind of rude. And I think if I spoke earlier this year at the American College of Physicians meeting, and one of the things if I was I don't know what, policymakers couldn't do this, but was to say to physicians, you got to open up this discussion about price and cost and the effect it's having on your patients because they're embarrassed to do it. And it's, I know Peter Ubel wrote a piece in the New England Journal about cost as a side effect. And I think it would be really great if the profession took that on, because I don't think, you know, yeah, you could have it a top-down from government, but that would be, I mean, in some countries, price lists are in every office. That wouldn't be a bad thing. In other countries, you know, every hospital in the U.S. has a patient bill of rights. Ours doesn't include having a sense of what your bill is going to be like. That is part of a patient bill of rights in Australia if you're paying yourself. So I think, you know, we have to think a lot more about those things, because it's really sad that people at this point of distress in their lives where they're suffering from illness, what they're worrying about is, oh my God, how much is this going to cost and how am I going to pay for it?
Doug, what about that conversation that physicians need to have with their patients? How do you create a culture within the medical community to begin that tough decision, to begin that tough conversation, to open that door?
I think it's very important, and I agree. I mean, you know, there is a conversation now about this being a real harm of an intervention, because you're at financial harm potentially. There are several challenges. One is that physicians may not know what something costs. And so if I'm practicing here, for example, Stanford has contracts with many different payers. The cost or the price or what someone will be charged for a particular thing depends on the particular contract and it may be different for one person than the next. It certainly is. So it'd be very hard in many respects for people to know that, for the physician to know that. There are efforts here and other places to help them with that. But that's one of the challenges, is that you first have to know what a person's exposure might be, and if you see 15 people during the day, it could be 15 different answers for the same test or procedure. So, and then I think, you know, we haven't really had a culture of doing that. We haven't considered financial things as a harm, and in the distant past, I think it was less of an issue than it is now. But I mean, Libby's fantastic series has shown just how catastrophic this can be for people, and it's one of the most important causes of personal bankruptcy is healthcare costs. So I think it's something that we need to take on as a profession and think about, but there's several challenges.
You wrote about a new drug, Sovaldi, the first drug to cure hepatitis C. And when it came on the market, it was priced at $1,000 per pill, which would be $86,000 for a 6-month regimen. And since then, Gilead, the pharmaceutical company, has reached an agreement with several generic drug makers to make this drug in developing countries at much cheaper cost. What did you find? What's the story here behind it? And Doug, I wonder if you would weigh in here about how do we assess the value of these interventions?
So Sovaldi is a great example, sofosbuvir. It's a revolutionary, and the drugs for hepatitis C in general, there's been a complete revolution in the past few years. There are two things to think about when you're assessing sort of the economic impact of a drug. One is the cost effectiveness. Cost effectiveness is a measure of efficiency. It's like miles per gallon. And you're comparing one strategy to another and trying to understand how much value do you get for this. And it turns out that sofosbuvir, with some of the older drugs, interferon, can be cost effective in some groups. And somebody here at our center, Jeremy Goldhaber-Fieber, just published a paper this week about the cost effectiveness of the drug. So under some circumstances, in prisons. And so in some circumstances, it can be cost effective. A separate question, though, is the affordability, which is the total amount of money that you would have to spend to, say, treat everyone in prison or treat everyone in the VA who has hepatitis C. And you can have something that is cost effective, but is not affordable in the aggregate because the total sum is going to be so high.
Because the state of California, for example, does not have allocated that amount of money for pharmaceuticals within, you know, the state allocation to go to prisons. They see it as a budget buster.
They do see it as a budget buster, and you can see why. Even though in some combinations or some people it might be cost effective, it can still be a budget buster. So you really have to ask both of those questions and then try to decide how, if it can be good, if it can provide good value in some circumstances, how can you prioritize people so to do this within a budget? And this is an issue, of course, not just with hepatitis C drugs, but cancer drugs and many, many other things.
How would you, if you were asked to consult to the prisons of California on this issue, what would you be asking them and telling them to weigh when they look at this? The overall impact of the drug will, in the long term, decrease significantly Hep C in prisons, yet it's a budget buster in the short term.
So part of the issue is whose perspective are you choosing? So a lot of the benefit from treating somebody with hepatitis C might occur after they're out of prison. So the prisons are looking at a particular budget, and they have many other things, and they may bear the cost, but the benefits accrue later. And that's not just a problem in prisons, it's a problem with health insurance in general, et cetera. So I would help them think about who gets the most benefit and what group of patients does it the most value, and how could you do that over time to do it within a particular budget constraint. And so that you can try to knock off the highest value groups first within a particular amount of money that you have to spend. Recognizing, though, that they may be bearing the burden for benefits that are much broader, but not actually seeing those benefits directly.
Yeah, I would. I think in a way, though, I would ask a more fundamental question, which is, why does it cost $86,000? I think, you know, the way we have priced medicine and treatment in the U.S. is often, I don't always know, and this is probably a more kind of radical fundamental question, is cost-benefit analysis always the right way to think about things? Because I remember, you know, you want to price lithotripsy, for example, breaking up kidney stones, and you say, oh, well, that's you know, does away with the need for 3 days in the hospital, which would cost, you know, at that time maybe $15,000. So we'll price lithotripsy at $14,000. Well, maybe we
$14,999.
Right, right. So maybe we should say, okay, yes, you know, Sovaldi is less than a liver transplant, but maybe that's not the right yardstick to be using. I know that Kaiser says, you know, Sovaldi, if they treated all their patients with Hep C, would double their medication budget. Now, what's that going to do to everyone's premiums for the next few years? So I think we have to be, you know, in a way, I would love to see our culture ask a bit more of these prices. I remember when I was practicing in the 90s when the HIV/AIDS drugs came in. I mean, they were revolutionary, more revolutionary than Sovaldi. When I started, I'm sure it's the same with you, you know, when I started my internship, people came in with AIDS and died. And then I watched these drugs come in, and I remember when they were priced at $10,000 a year, people were horrified, you know, horrified. It's too much. No one should have to afford that. You know, I think what's happened in the intervening 15 years is we've been so inured to high prices that, you know, $10,000 we go, oh yeah, that's, you know, that's pretty reasonable. So I think we have to ask when these new drugs come in at these extraordinary prices, we have to somehow do what other countries do a little more and say, you know, that price is too high. You know, we want to be able to use it more broadly. We understand that maybe the U.S. is supporting R&D globally. Maybe we shouldn't be. I mean, these are very fundamental questions. I mean, is it all for R&D? I think that's something we have to ask. And you know, these are. I don't know. I know a lot of people are feeling like the Sovaldi pricing may be a good thing because it's pushed this to such an extreme example. I mean, the latest thing I'm watching, and I hope everyone will watch with me, is Gilead is now offering the maker of Sovaldi to pay the first month free for Medicaid patients. Okay, so what does that mean? You know, it's a strategic, and this is the strategy I'm talking about. So how are we going to respond to that? That still leaves you with, you know, $46,000, and now the providers are on the defensive because the drug maker can say, well, look, we're giving a month away free. You know, patients respond to that.
So when you call Sovaldi and you say, or when you call Gilead and you say, I'm doing a piece on Sovaldi, and I want to talk about the price, et cetera, how does the pharmaceutical company respond to you in the way in which they create their story about why this is fair, why this is equitable, why this is just?
Well, I mean, every segment has their own narrative that makes sense within that silo, which is, you know, we've spent all these years developing it. You know, we in this case more, we spent a lot of money buying the company that developed it. They did a lot of testing. You know, it's a revolutionary drug, which it is. You know, and it will save a lot of expensive care later. The fact that we don't really know how to deploy it very well at this point to kind of maximize that benefit is really not their concern. So every segment, when you call them, has their narrative. You know, the problem isn't us, it's them.
You probably heard them all.
Well, and I think it's when I call around, it's everyone pointing at everyone else, and which is why I feel like everyone has to give a little, and I don't know how that's going to happen.
We've moved in this country towards a great consolidation of practices, and it's rare to see any small practice much anywhere, and maybe perhaps in rural parts of the country we do. Yet new research from Stanford in the last couple of weeks has said that this consolidation has not lowered costs at all, that it has erased competition essentially, and so the impact overall has not lowered costs. How do we get the economics in line with these new practices? Is that possible? Is that doable? How do we approach that, Doug?
So the way that people have thought about, one of the ways is to engender competition between groups. And so the markets vary greatly in terms of whether there is competition and how much the competition makes a difference. But as groups have consolidated, and take this market, for example, where we have Sutter and Kaiser as humongous players, and in Stanford and other groups, you can imagine that there is some competition among those, certainly, but the more consolidation you get, the less there is. And so that is a complicated problem, I think, where you have, even if you have economic incentives that help align for a particular group, so you're paying people in an accountable care organization, or et cetera, to try to maximize the health of a population. If there's not other alternatives that they're competing with, they can still charge whatever they want. And so that is, I think, largely an unsolved problem here, and an important one. And this story is, I think, continuing to play out.
Yeah, I think one thing that I see as being a very quick possibility, which I know is on the table, is part of what has happened recently with consolidation is not so much consolidation within systems, but the consolidation of doctors' practices as part of hospitals. So what we see a lot in the Northeast, I'm not so sure how much it's happening here, is that the echocardiogram you might have had in your doctor's office for $500 will now be done in your doctor's office, but since your doctor's office is now part of the hospital, there'll be you know, a $1,000 facility fee tacked on. So you know, there's an example where consolidation works very directly against cost and patient interests. I know Medicare is thinking about site-neutral payments, which means You get your, because obviously it's this game of strategy. If you're paying more for things done in a hospital, which we do, and for good reason, because hospitals have a lot of overhead, the long-term tendency, once people get smart in the business of medicine, is going to be to move all of these kind of trivial procedures into a hospital so you can charge a facility fee. So, and I think we're seeing a lot of that now. I'm not sure about in this market, but in the Northeast.
But that's an example of a perverse economic incentive that can work against us, and that people respond to that economic incentive in as creative ways as they can. And so, if we don't get that part right, if you reward people, you pay them more for doing something in hospital, that's what they'll do.
The big bad word in healthcare and in politics is rationing. And said another way, it's utilization, right? And in order to control costs, a number of health economists believe that we're going to continue down this bumpy road, and then some financial crisis is going to hit. And then once again, there'll be sort of the drive to what do we do, how do we control costs? And ultimately, that word may come back into the reality of the healthcare system, utilization, healthcare. Americans get everything, they want everything at the moment they want it, and they seem to get it at the moment they want it, versus other countries where it's much more controlled. How do you see that playing out in the future, utilization and rationing, and really taking, and just letting the American people know that when you want it, you can no longer get it in healthcare because the healthcare system can't afford it?
Well, I would start by saying that we need to recognize that we've been rationing. We've rationed based on your ability to pay, which I think is the most inequitable possible way to do that. And so many people have gotten little health care because they had no way to pay for it. Now, the ACA may ameliorate that to some extent. There's a lot of what we do that provides little benefit, or no benefit, or is actually harmful. And so the first step, of course, is to try to eliminate that. Not so easy to do, but to try to eliminate things that don't help. Then look at the value of the remaining things and make sure that you're not eliminating high-value services. For example, Medicare is considering across-the-board cuts, and that is as opposed to trying to figure out which services don't make sense or not providing value. And you run the risk of throwing the baby out with the bathwater there. So I think there's some steps that we can take to eliminate things that aren't doing any good, and then focus on the value of the remaining things. But in the end, there is going to have to be a conversation about that for low-value things, that if people want them, it's not clear that we as taxpayers ought to provide them.
Is that an expectation that you feel that, when your comments sections from all the pieces, is that something people talk about? Is that something that people think about?
Really not. I think, I have New York Times readers who comment. I suspect there are not a lot of Tea Party commenters on Paying Till It Hurts. But I think, to me, the rationing debate is something that came along with the whole worry about death panels, that we are so far from rationing. I mean, when you look at the studies, I think, how many people get colonoscopies way more often than they're supposed to. How many people, when I was doing that first piece on colonoscopies, I was getting distress calls from geriatricians who said, my 95-year-old nursing home patients are being told they need colonoscopy. I mean, I feel like we are so far in insured patients from rationing that, boy, we've got to deal with this, misutilization and misalignment. And yes, at the end of the day, there's probably going to have to be some talk. But boy, we're so far from there. We're not. And so I feel like rationing is a little bit like one of those bugaboo words with like death panels. But I haven't heard anyone say, "Wow, I mean, most of my comments are like, in that vein, are like, "Wow, I was told I need this. Is that true?" And I'm like, I used to be a doctor, but my doctor says I need to have, 10 radiotherapy treatments for my basal cell skin cancer, and I'm not sure if I need this, So I think people have their antenna up now for, and this is unfortunate, is my physician telling me what I really need rather than in what's in their interest? Do I really need anesthesia or propofol for my colonoscopy? Now that I hear from everyone who kind of went without sedation in their colonoscopy and had a good time and had a great conversation with their gastroenterologist. But I think our assumption that, and when you would go into a surgery center, you need it with an anesthesiologist, and certainly Joan Rivers' experience in New York has reinforced that. But it's a complicated message that we take for granted, because in most of the world, people don't have anesthesiologists giving them propofol for their colonoscopies, but they do get colonoscopy. So.
We're going to take questions from the audience in 1 minute. I just want to ask one final question. If each of you were in power, and what transformation in the healthcare system would you immediately put into place? What are the 1 or 2 or 3 things that, from what you observe of the system?
I was going to say, Libby should go first.
Clearly.
Yeah, I hate to say this because I think, well, I got louder, I think. I don't think, and I'll say this, I don't think transparency is the solution, but I think it's a certainly good, easy first step, in that I would like to see every hospital, including here, make their charge masters public. Not that I understand that those are, notional prices, that no one really charges that. The first thing I think it would happen though, and I wouldn't mind seeing prices on order forms and in doctors' offices, understanding all of that, insurance has different contracted rates. But I can tell you, I had my colonoscopy at Sloan Kettering Cancer Center in New York, where they have a screening colonoscopy clinic, and it was billed at $12,000. Now, if anyone had to write that down on a price list, no one would charge $12,000, I can promise you. So I think part of putting things on paper is starting the discussion about what's reasonable. And until you can look at those price lists and until there's a bar, then you can't even start talking about it. I often use the example of hotel rates. No one pays the rack rate, but you can know what it is. So I think there's a value for having a bar and starting the discussion. I also am not quite sure why order sheets within hospitals shouldn't tell doctors this is what we charge for these different tests. Because I think part of the problem, as Doug said, and as I hear from physicians over and over again, is, gosh, I sent my patient I did a hernia operation, and I saw the bill, and I'm shocked how much that the OR time costs. I'd had no idea. So I think, more transparency would be a good starting point, not an end point, but a starting point.
Doug.
Well, broadly, Vic Fuchs has written about this, and comprehensive healthcare reform, what would involve coverage, cost control, coordinated care, and choice. And I do think those are the right elements. The cost control, I think, is going to depend on, to have a system that gets a handle on cost control, I think you need several things. One is you need to know what works and what provides good value. That's often not known, and when it is known, it's often not used. Along with that information, you need to have economic incentives that would encourage you to actually do what works and what provides good value. And then the third thing is that you need the tools, the management tools, both on the clinician side to help implement those things and tools to understand how to manage a population. So I think that the things that to control costs, we at least have to have an understanding of what works and provides good value, economic incentives that encourage that, and then give the providers and the healthcare systems the tools to really manage that process in a way that they can accomplish those goals.
Thank you, Doug, and thank you, Libby, and especially thank you, Libby, for the series that has really helped elucidate and help put a significant spotlight on the problems.
Discussion or promotes more discussion of this. So,
thank you. We'll take questions from the audience. I think there are microphones. Is the microphone there?
Hi, so I had a couple questions. I know there's a movement towards shared medical decision-making, and I was wondering how these sorts of things and tools, because there's a lot about patient decision aids and those sorts of things, and it just seems like with the computer age, it wouldn't be that difficult to populate something with the costs and, buy insurance and that sort of thing. So whether or not there's discussion among people doing that sort of research and work towards that. And also if we're moving also towards the science of de-implementation, because you mentioned, there's a number of things that we could probably stop doing, but there's also a psychology of people feeling like if you do more, they're getting better care. And so whether or not we also have to train patients, because I know for myself, when I went in for something and they didn't order something, I was like, should I be getting, an x-ray or what have you? And she said, well, actually, the research suggests that it isn't actually much better than a physical exam. And so she actually sat and explained to me, there isn't much evidence that this is actually better, so that's why I'm not recommending an x-ray. So I think, to Dr. Owens's point about there's really not a lot of research on all sorts of, the practices and that sort of thing, I think providers also feel like they should just order it because, insurance will likely cover it for some people, and I think patients probably feel better when they get more procedures. So there's a psychology around that as well.
Yeah, I think, one of the most harmful phrases I remember or financially harmful phrases I remember from my days as an ER doctor, was why don't we just get, and you hear that over and over again. Well, I'm not sure. Why don't we just get a chest x-ray? Why don't we just draw some bloods? Why don't we just, so I think the science for deciding, why don't we just is not a good reason. And particularly for people who are insured, I'll hear, well, let's just get an x-ray. You have good insurance. Well, that's something I think I would like not to see anymore, right? That's not a good idea. In doing the last article on back surgery, I was talking to James Weinstein, who's a back surgeon at Dartmouth, and one of the things they're looking at there is not informed consent, but informed decision-making. So, informed consent, the model is the doctor decides what you need, and then you just sign the form. But what if a doctor sat down and said, here are the pros and cons of back surgery. Here's the cost. And you know what? With computers, I probably should be able to tell you exactly what I mean, not that there's much incentive to program that right now, but it should be possible. And you decide. Someone I know was sent, someone who's on. Who wrote to me was sent for a sleep study for $5,000, right? And she said, which I think is true, if the doctor had said to me, we can send you for a sleep study, but it's going to cost $5,000, she would have said, you know what, why don't I try counting sheep or doing but we don't have it. So I think instead of this idea of instead of informed consent, it should be informed decision-making with the cost component folded in, I think is a good idea. This, by the way, and I have to do my plug here, came in through we have an association with Pain Till It Hurts, our series, a Facebook group. And this came in on the Facebook group. It's wonderful. Anyone who's interested in health reform, it's just Facebook groups, Pain Till It Hurts, all one word. And it's a great place where both patients, physicians, lawyers, hospital administrators, everyone's joining this conversation. It's really interesting. So, Doug?
First of all, I agree with what you just said. I think in a world of patient autonomy, to not tell the patient the cost of the procedure borders on an ethical issue. But my question is, would you please comment on the cost of end-of-life care?
You know, I was at at a conference over the weekend where I heard that some of that data is being studied now, and it's actually not going to be as high. The new studies show that it's not as high as we thought it was. But obviously, the same principles apply there. And often, you know, end-of-life care often occurs in hospitals where people really lose their autonomy. And I think in a way that's what the last story was about, the one about the patient bill. You know, all these people are coming in and doing things to you. No one says, you know, other than the DNR discussion, no one says, oh, here's the dermatologist to see your rash, here's the, you know, do you want, you know, you basically right now, the model is you have to say, which is kind of obnoxious when you're sick and lying in a hospital bed, who are you? Are you billing separately? You know, I don't need a physical therapist. So I think to me, and I mean, obviously end-of-life care is a big discussion that some of my colleagues have written about, but I think many of the same principles apply, that patients, when they're in a hospital, they turn into this kind of passive entity and things are done to them and they have very little say about that. So.
But isn't some of that mitigated with palliative care?
Yes, although I think I've heard a lot of, and I'm debating whether to do a story on this, there's a lot of strategy surrounding billing in palliative care too. You know, what I've discovered is that in every corner of medicine, even the ones that you thought should be cost-saving and are cost-saving objectively, there are people who figured out a way to monetize them, and it's really sad. You know, so you know, yes, it should be. It's not always. Thank you. Sure.
Great discussion. Thank you very much. Do you think that a unifying value metric can be defined?
I'll let you start this one.
Yes, and I'll tell you later. No, you know, I think that, so we do a lot of cost-effectiveness analysis where we try to evaluate how much do you pay for something, how much benefit do you get. We never think, when we evaluate the cost-effectiveness, that that is the only thing that you should base a decision about whether to offer something to somebody on. And so I think that understanding the value of interventions is, in many cases, doable. But it isn't the only consideration in terms of whether you would give something to somebody or offer it or cover it, et cetera. There are ethical questions, there are social justice questions. And so if you mean by a unified metric that allows you to say yes, no on everything, no, I don't. And I think that cost effectiveness should be used. Oh, sorry. Here we go. Cost effectiveness should be used in a decision framework that accounts for these other very, very important things like ethical questions and questions of social justice, et cetera, not as a single standalone thing.
There's a question, two over here.
Hi. Do you think that, over in the corner, do you think that the cost of a new drug should be considered when, I guess considered by the FDA when they're considering approving a new drug?
They don't know the cost.
Right. Yes, I do, personally. I'm not supposed to have an opinion, but when you look at some of the discussions that go on there, I think the notion that it is cost blind is just not realistic. I mean, they know it's going to cost something, so instead of being able to work with the actual cost, you often see these studies that assume different costs, and then the company comes out with a cost that's. So I think one of the things that always surprises me a little bit, and I think would be, surprises people from other countries even more, is that drugs get approved, and then there's this kind of you know, the market people speculate about what the drug maker might charge, and then we find out. And so, you know, obviously, value means cost at some level, you know, and to pretend that that isn't there, to me, is just, it's not saying that, you know, health is so valuable. I mean, health does have a price, and we have to, I think we could have more rational discussions if we said, okay, there's this new vaccine on the horizon, and this is what it's going to cost, rather than have these researchers have to say, there's a new vaccine on the horizon, it looks really promising, it could be priced at A, B, C, D, E, F, or G. Let's think about the cost benefit at each of those levels. I mean, you probably deal with that more than I do, but I would like to see more talk about cost up front.
So Stanford's done two things that I think are interesting regarding healthcare costs. And one of them is that, I don't know how you got here from the airport or which airport you came from, but Stanford Medicine is expanded beyond Stanford, California. And so there's cancer centers, there are orthopedic centers, there are all sorts of places, sleep centers to get treatment, which I assume are built in order to generate revenue from fee-for-service interventions. In other words, they're trying to get paid to do more individual units of service. And yesterday was the beginning of open enrollment for Stanford Health Insurance if you're an employee. And I know what insurance I'm buying this year, which is Stanford's self-insured health plan, their own HMO. If I wanted to continue to have Blue Cross through Stanford, I think it's about $1,600 a month in premiums. Did I add that up right? And it
went up 7%.
For my family. Some enormous number. But if you get Stanford self-insured healthcare, where I have the same access to all the Stanford doctors that I've used over the past year, my charges are my premiums are very, very small. And my co-payments are really very small. And so Stanford's done two separate things. One is trying to maximize its revenue, and the other to cap the cost of healthcare for its employees. Could
Just
either of you?
Sick outside of the Stanford area.
Well, can you?
I mean, that's what you're paying.
No, there's still only a $6,000 catastrophic cap. So, which I reached in my insurance this year. So, thank you for reminding me to schedule my colonoscopy before the end of the calendar year. But would you care to comment about those two separate things, the fee-for-service piece and the HMO capped cost kind of way of approaching healthcare?
Okay.
Well, so I can just tell you that Stanford is facing, the healthcare system is facing different incentives, because in some services they get paid fee for service, and so that involves a particular strategy. And Stanford has launched the Accountable Care Organization, where they're going to be paid, in part, in simplified terms, a certain amount to try to take care of people, and that is a real pivot, because then you're facing the incentives to take care of a population and keep them healthy, as opposed to doing more things to them, like, you know, go to Midas, you get a muffler, right? And so there's this schizophrenia that the healthcare system has to deal with, because they are facing both of these sets of payment schemes. And I think it's very laudable that Stanford has launched the ACO and is trying to figure out how to do that. And we think that that's the way the reimbursement is going to be handled more broadly in the future, and that's going to require a big adjustment on the part of healthcare systems to understand how to do that well.
And I think one of the interesting things is long-term I think there are a lot of really interesting experiments going on at places like Stanford and Mayo and Cleveland Clinic, just to name a few. They're all over the place. But I think, to me, and I don't know what Doug thinks about that, one of the interesting things is going to be, can institutions remain these kind of hybrids? If part of you is making money fee for service and the other part is doing accountable care, won't the temptation always be to fund your the part you don't get paid for with sleep studies or $4,000 echocardiograms? Likewise, a number of places that are doing these kind of network approaches, they still pay individual physicians with productivity bonuses. Is that going to work? Or do you really have to go to this model of shared income? So I think there are a lot of hard questions that institutions are going to have to deal with.
There's a question over here. I'm not sure about this, but is it the case that by law Medicare cannot negotiate with the pharmaceutical companies for the price of drugs? If that's true, would that be a factor? And what's the rationale for that?
Yes, that's true. I believe, although I'm not 100% sure, that that was brought up in the debates over the Affordable Care Act, and it was decided that the ability of Medicare to bargain on pharmaceuticals, that they wouldn't get buy-in from the insurance and pharmaceutical industry to get the ACA passed, and that was the priority. That's my understanding. I don't know. That's correct. And so I think if Medicare could bargain, I mean, Medicare kind of sets a yardstick for what insurers do. And so, yes, that would be a huge, that would make, I think, for a big change in drug pricing in our country.
And let me give you a counterexample. As you know well, Rex, is the VA does bargain for prices. And we don't pay $1,000 a pill for sofosbuvir. And the VA gets, very, very competitive prices as the largest healthcare system in the U.S. So there are opportunities for that. Would that solve the bigger picture? No, but it might help.
Hi, ma'am. I just have a question. I used to work for a company called Prudential. So I've signed off policies like $2.5 million with critical care riders for cancer, long term. Is the medical community aware of such kind of things, and is this something that's really useful?
I don't know much about that. Do you, Reg?
I don't either. So I'm sorry, there are caps? Or is that the policy?
No, we used to sign something like, it's like a life insurance, but with the critical care rider. Mm-hmm. Suppose you did get cancer after 60, 65, the policy kicks in. It's a $2 million policy, and then it'll cover your cost for medicine and their long-term care insurance. And I always used to wonder if this really works.
I don't know the answer to that.
I don't know the answer. One thing I would love to know is the idea of a $1 million hospital stay. It's really easy to get there in the U.S. with a serious illness. I don't know if it's that easy to get a $1 million hospital stay in other countries. I mean, our per-day hospital charges and test charges are just so much higher than other countries that maybe that's part of what we have to, we're almost like callous to hearing about cost, and that was part of why I wanted to do the series. We accept that healthcare has to come with these incredible prices, and it doesn't in most of the world. And I think that's one thing we have to be asking ourselves and our politicians. So.
Have you heard from politicians? Have you heard from Washington? Anything, the series?
It's one group I haven't heard a lot from, although I've heard bits, and not from Washington. Some states are doing very interesting things. The state of Maine is, I don't know how many of you have been following their prescription drug effort there. They're allowing people in Maine to mail order prescription drugs from pharmacies in Canada, Great Britain, and Australia and New Zealand. They're waiting to see the Pharmaceutical Manufacturers Association tried to sue them. They said they don't have standing to do so. Some of the local pharmacy chains are suing them. And I think everyone's watching that very carefully. This is not just like buy your drugs willy-nilly over the internet. This is from licensed pharmacies in those 4 countries. So that's a really interesting experiment. If that goes forward, that could be a big game changer if other states follow. Likewise, a lot of insurance commissioners are trying to do interesting things, but I think they're all feeling like kind of pretty much lone wolves trying to get something done against, fairly big odds.
Hi. Thanks for this great discussion, by the way. One of the players that I haven't really heard mentioned so far is the training institutions. And I was wondering if you could speak a little bit to the financial incentives that are generated by such a high cost of medical education and the loans that the doctors have to take on.
I think in terms of the financial and the situation for students coming out can be quite daunting. And so when I decided, I'm a general internist, and when I made that decision, specialists made more than general internists, maybe 50% or something like that. But I wasn't facing a situation where I could make 4 or 5 times what I make by going into a subspecialty. And so I think when people come out with debt, you can imagine facing someone making a decision where the disparities in income are so remarkable that it's really hard to ignore that. So I do think that that creates an incentive for people to go into specialties that are highly paid. And it's, but it also, the fact that we pay those specialties like that is symptomatic of the larger issue about how, whether the economic incentives really make sense in terms of the kind of care we want to get delivered.
Yeah, I think we have to talk about, reevaluating physician compensation in the specialties particularly, because often you find that the higher paid specialist, that doesn't really correspond to training or difficulty of practice. It conforms more to the ability of that specialty to have figured out a way to monetize what they do. The thing I do say, because I've spoken to a bunch of medical school classes, is I have lots of friends who are unemployed journalists, many in fact. I know unemployed lawyers and unemployed bankers, but I don't know unemployed physicians. So I like to tell students to follow what they love to do, because life is long, and that matters in the end, because I think payment reform is coming, whether the specialists like it or not. I mean, the National Commission on Physician Payment Reform was co-chaired by Bill Frist, a good Republican, and they said fee-for-service payments to physicians have to end. So I think, at this point, if I had a kid in medical school, I would say, do what you love.
So a lot of this conversation obviously is around intervention and procedures, but what gets lost is sometimes the conversation about prevention, and I think that's also the conversation within primary care versus specialty care, where the primary care model is more about prevention of and catching things early. Can you speak a little about what role that can play, or how we can incentivize more preventive type of programs that could help control the cost of healthcare?
Well, in my big group of people I hear from all the time now, I heard recently from a bunch of primary care doctors who were so thrilled that I think it's Medicare is now paying them $27 a month in New York to manage some of their patients with chronic conditions, it wasn't for any specific thing. It was just kind of for being their doctor and for being available. So I think we need to think of other kinds of things like that allow doctors to spend more time doing preventive care. I mean, when I talk to people with type 2 diabetes who said, many of them knew what a better diet would be, but they said, look, buying fresh fruit and vegetables is really expensive where I live. So it's almost like rethinking how we define medicine. There's a really interesting project called Road to Wellville, which is being funded by Esther Dyson, who's an angel venture capitalist. It's taking 5 communities and just trying to see what you can do in communities to promote better health. I'm PS now, since I'm in this kind of close to Silicon Valley, I should say, there are a lot of iPhone apps out there that purport to do this. I predict most of them will make some money but not help people very much with their health.
The ACA, as you probably know, mandates first dollar coverage for preventive interventions that are recommended by the U.S. Preventive Services Task Force. And we're looking at that. I'm on the task force, and we're trying to look to see whether that's made a difference or not. I think that's an open question about whether or not that's going to make a difference in utilization. And if it does make a difference in utilization, is that going to translate into better health outcomes? And I think that it's also not really a foregone conclusion that, I mean, preventive care is good, but probably not necessarily for the reason that it's going to lower costs. I think that's less certain.
Doug, since I have someone from the task force sitting next to me, I should mention that one of the unusual fees that I saw in the last article was people who got preventive care, which should have been covered 100% by the ACA, and suddenly there was some, I think this is, when we say, oh, preventive physical should be covered, right? So if you're creative and trying to make sure your income stream stays up there, you say, oh, I'm sending off your blood tests and I'm putting in a thyroid function test, which, is that preventive or not? And so we say preventive services and should be well covered, but we don't define. I think in this day and age with all this strategic business stuff going on, we have to define really specifically, oh, prevention means IUD plus putting it in,
I'll just give you a couple of other examples of that. So for the chair of the task force, past chair, went in to get her colonoscopy and then that was covered but got a bill for the biopsy of the polyps. And so these people unbundle these things. And so, for example, lung cancer screening, we just recommended lung cancer screening with CTs. But I've done 2 of those in my practice, and both of them discovered other things that need to be evaluated. And so those things probably wouldn't be covered. So it's very complicated, and a covered prevention intervention might discover other things that would saddle you with costs but not be covered.
I would argue that as a society we have pretty poor health literacy, and while shared decision making and transparency is a great idea, in modern medicine the decisions we're facing are really complex and nuanced. So how does this lack of patient education hinder the feasibility of that kind of system, and what do we do to address that?
Okay, I'll say, I mean, I think that I haven't been to Dartmouth, I haven't seen their model, but I do think some of our lack of patient education is from our, here's a consent form, sign this, rather than, and I understand doctors are really busy, there's not time, but I think, and and the internet has all kinds of bad education as well as good education. So I think we need to figure out a way to reimburse providers for doing that kind of education. I don't know, Doug, do you have a good answer? It's hard.
I agree with what you said, and I think if you paid people to help do those kinds of educational things, then it would get done. I think the shared decision making is useful and helpful in some circumstances. Adding cost to it would be challenging because the costs are highly variable, et cetera. But a key thing is helping people understand how their preferences for different things, how they feel about the quality of life with different things ought to influence their decision. And I've been in the business for quite a long time, and we've been saying that we're going to, there are going to be decision aids to help people do that, and that's been going on for 20 plus years, and we really still haven't made that much progress. So I agree with the premise that there are a lot of decisions where they really are difficult decisions, and we don't do such a great job of educating people about them.
We have time for 2 more questions. One
yeah, thank you for your series of articles. It's a nice companion to an earlier article that was by Stephen Brill, you know that one, sure. In Time Magazine that occupied that entire issue from a year and a half ago. So I recommend that one too. But one of the things that is kind of bothersome to me about this whole issue of healthcare cost containment is that it really requires tremendous courage on the part of the leaders of the institutions to do that, especially if doing the right thing might negatively impact the revenue flow into that institution. So how do you address that?
That's a really hard question. I think, to me, the premier example of this is how hospitals and hospital rooms look in the United States compared to, I think I've been at dinners where people have said to me, oh, I'm so sad, we couldn't rebuild our hospital with all private rooms. And I'm like, okay. I would encourage everyone in the room to look. We did an online quiz called Is This a Hospital or a Hotel? And it was pictures of 12 pictures, some of hospitals, some of hotels, and you can't tell the difference in the US. There is also a picture of one of the patients in the series went to Belgium to get his hip replacement, to one of the best respected hospitals in Belgium. It looks like a hospital that no American would go into. So if you were a hospital CEO, I mean, you can't just say, I don't care about these things. You've got to keep your patients' flow going. But I think part of it is educating patients to what really matters, that the free coffee in the lobby doesn't matter so much. There are all these billboards, all private rooms. Well, has there been a good study showing that all private rooms matters? And then P.S., I've seen on hospital bills at hospitals with all private room surcharge. So the shenanigans are endless. And I think it does take some really brave leaders to say, I would love to see a hospital in New York that said, we're just going to do health care. We promise you no surprise charges. Your rooms are not going to be fancy. You may have to go out to the corner to get your coffee, but it's, health care is us. That's it. No amenities.
Bunk beds.
No, not bunk beds.
One more question.
Yeah. My wife and I have. Do I have it? Okay, great. Elizabeth, my wife and I have seen through a variety of healthcare conditions in our family all the games that physicians, that hospitals, and that insurance companies play. And my wife, God bless her, spent a lot of time learning about this and fighting back. And we managed to not only be able to confirm all the things you wrote about in your articles, but also get the charges eliminated. In the spirit of Silicon Valley, it seems to me there's an opportunity here for a business, a nonprofit or for-profit, I don't know, but patient advocacy, because how do you, if you're going through breast cancer or whatever, how do you have the time to learn to find out all the games that insurance companies or doctors or hospitals play? There's got to be somebody out there that does this. I mean, I've seen lots of other industries where you have people that will go in and audit bills on behalf of a business or an individual.
Well, I think there is a kind of industry now in patient advocacy, just as there are navigators for the Affordable Health Care Act. While I think they're all really good, and so, I mean, in Steve Brill's article, those patients were patients who'd been to a patient advocate. I think, the problem is patient advocates also charge money, so unless you're dealing with the $100,000 bill, it's not likely to be in your benefit. And I think patient advocates and patient navigators, and I know some people will not like me for saying this, are a symptom of a really dysfunctional system that's way too complicated. I was writing about last week complicated charges on patient bills, and I opened my email this morning and get a kind of pitch from a company that is working with hospitals to add another layer to take those complicated bills and send out a simplified bill. Okay, well, why, part of the problem in our system is that as we see one problem, we rely on the profit motive to bring in a solution, and that in the end, I think, fuels even more costs. So there are some really interesting sites that are out there, like goodrx.com for pharmaceuticals, and some clear health costs, healthcare blue book that give you good estimates of what things should cost in your area. And boy, in the meantime, I think it's really helpful to patients to have a look at those before they schedule elective stuff.
Thank you, Elizabeth, and thank you, Doug. Thank you for coming, everyone.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.